to get started with your cardiac PowerPoint. So we'll go ahead and start with this one. And remember, like I talked to you in class, I said that you'll have a separate dysrhythmia PowerPoint. So the beginning of this one, we'll just kind of go over a little bit about the EKG or ECG, and then the rest of it will be on STEMI and cardiomyopathy. So as you can see, this first slide just kind of talks about what your module objectives are in your course, and that's straight out of your Canvas. This next slide here is just a quick overview, just talking about the basics regarding the cardiovascular system and how it functions. So the primary job, as we know, of the heart is to propel blood from the left side in throughout the circulation and then have it return back to the right side. So the cardiac output here is, this is how much blood the heart can eject out into systemic circulation. And then as it goes on to talk about, then that when it goes throughout the system or the body, then we're delivering oxygenated blood to the tissues and then returning deoxygenated blood to the heart. Okay, this next slide is your EKG or your ECG, and this is just showing your PQRST and then a U wave. Not always do you see a U wave. Basically, the basics with this is just to remember that your atria is reflective in your P wave and your ventricles are reflective in your QRS. And then that way, when you have atrial dysrhythmias like AFib, things like that, you can see where that's coming from above the ventricles, and atrial fibrillation, there's no P wave. And you can see how that's an atrial dysrhythmia. And then, like I said, the ventricles depolarization is your QRS. This next slide here, I really like this slide because it shows the intervals and how to map them out. So this could be something that you could reference back to if you don't remember how to map out a PR interval or a QRS segment. You can look back onto this slide, and it shows it very well exactly where the measurements should be taking place. Pretty much what this is trying to say is that for a normal reading on a ECG, you have to have this sequence of events taking place. So you need to have a P wave followed by a PR interval, followed by the QRS, and then the ST segment, and then a T wave, and then the U wave if it's present. So that's just really what this is going over. I am going to talk a little bit about pacemakers on this PowerPoint. There's just a few things that we need to kind of be aware of with pacemakers. So there's, you can have temporary pacemakers. These could be transvenous or, which is what this is really kind of talking about, where there's wires and the wires will come out if they do it like transvenously through the femoral, or if they do it through the IJ or something like that, then those wires come out and are connected to a pacemaker box. And then settings are dialed in on the pacemaker box. This would be a temporary pacemaker, and these patients would be in the ICU with this. A permanent pacemaker is where they take the patient typically to cath lab, and then they make that incision and they permanently place or implant a pacemaker or an ICD, which is an internal cardiac defibrillator, into the patient's chest. And those last for a period of time. It says here about around batteries around 10 years, then they have to go in and replace the generator and things like that. But that's a permanent pacemaker. Um, I kind of wanted to talk a little bit about this slide. This is just talking about, post-procedure, if somebody had a permanent pacemaker place, then what the nurse would be doing and documenting. The big thing to remember, the big takeaway to remember is anytime, like, when the patients go into the cath lab to have this procedure, or really to have any type of cath lab procedure per se, they're usually doing this under sedation or monitored anesthesia care, but they're sedated in some way. So when they return from the cath lab to the floor, the big priority is always going to be your ABCs. Sometimes we don't think about that, and we're like, oh gosh, we have to get them on the monitor so we can see what their heart rhythm's doing, since they just had some, quote, heart procedure like a pacemaker implantation. But remember, you need to keep in mind that they did have sedation. So ABCs, airway and breathing, we should always be assessing that first, and then circulation. And then after that, then we can hook everything up. So one thing that I always like to do is when they return, you're always looking at your patient, what's their level of consciousness. That's a great way to see kind of how their ABCs are, how their airway and breathing is. Are they able to maintain their airway? Are they answering your questions? So assessing their level of consciousness is a good way to monitor for that. Okay, client education. This is taking, or this slide goes over client education for a pacemaker or an ICD. So it's important to know that when they have these procedures done, it says that they will be taking or having an identification card that they take with them all the time. You guys can like read through this, but some highlights would be making sure that they do have that identification card about their pacemaker or ICD. Typically, these patients will have their arms or their arm in a sling to immobilize their shoulder. That way, they're not stretching that arm around and dislodging the wires that they just got done implanting in the heart with the pacemaker. So they'll have them wear a sling when they're out of bed. We do teach them not to raise their arm up above their shoulder for about 1 to 2 weeks. So a lot of times they will go home with that sling and be wearing that, like I said, out of bed for a week or two post permanent pacemaker or post permanent ICD implantation. It's important to teach these clients how to check their pulse so they can make sure everything's good with that, and they're educated about that. And then it goes on to talk about that they should report if they're feeling any dizziness, fainting, fatigue, weakness, chest pain, hiccuping. These could all be dysrhythmias that are happening that are causing this. So it is important to teach those signs and symptoms of what that would feel like if they do have any dizziness or maybe go into a irregular heart rhythm. The hiccuping has to do more so with perhaps the generator or the pacemaker is pacing the diaphragm of the patient. So that would be something that we would not want to happen. So if they are having hiccuping, then it's important that they report this to their provider. There's always some myths, I guess, that clients seem to have, and it's important to dispel these myths. One of them is a big one with people that have pacemakers is they say that they can't utilize a microwave, and that's just not the case. So you can see there that it talks about that these patients can use a microwave, and it basically goes on to say that we just want to make sure that we just don't have items that can affect the settings of the pacemaker. So it goes on to say, like, don't put anything that can generate a magnetic type field directly over the pacemaker. They should not have garage door openers close to their pacemaker, strong magnets. This goes on to say large stereo speakers, but it does say the use of household items is not prohibited. So it is important to kind of talk to people and dispel that myth. Another thing that it's important to teach is that we need to teach them that to inform airport security personnel that they have a pacemaker or an ICD, because they need to know this. A lot of times, if you go walk through that, you know, security for the airport, there sometimes they use that wand, and they just kind of run that over the person. We need to make sure and let them know that the airport security personnel should not place the wand detection devices directly over the pacemaker or the ICD. So those are some important things, and then just dispelling those myths. I guess the difference between an ICD and a pacemaker, just think that the pacemaker paces the heart, so it helps slow rhythms beat faster. And then the ICD defibrillates the heart, so it stops fast, dangerous rhythms with a shock. Another thing to kind of keep in mind is we should tell people if they do have an ICD that they could have loss of consciousness right prior to an ICD shock delivery. And that does make sense. If they go into a lethal dysrhythmia, then clearly they would lose consciousness from that. And then the ICD would deliver the shock. It does feel like a big blow to the chest, and it's extremely uncomfortable. So it's important to let them know this. Basically, the ICD, shocks them back to life. So, okay, that's pretty much it on pacemakers. And then, like I said, the rest of the dysrhythmia PowerPoint, you guys have a separate PowerPoint for that. So I'm going to go right into myocardial infarction. This slide here is a good visual slide, just showing the difference between what vessels would look like if they had unstable angina versus an NSTEMI versus a STEMI. And you can see there in the STEMI or the NSTEMI, which is a non-ST elevated MI, and a STEMI, which is an ST elevated MI, you can see the difference as far as the thrombus, how big the thrombus is. Like, you just have total complete occlusion with a STEMI. So as far as a unstable angina, this would be pain that is not associated with exercise, and it's not relieved by rest. When you have stable angina, those clients know that, oh, when I do this exercise, I have chest pain. When I stop that exercise, my chest pain goes away. That's stable angina. So unstable angina is pain that is not associated with exercise and is not relieved by rest. In your book, they have a good table in there that's on page 708. It's table 32.2, and this shows the different characteristics side by side of unstable angina versus non-STEMI or a non-ST elevated MI versus a ST elevated MI or a STEMI. So that's really good to look at that too. You can still have EKG changes with a non-STEMI. A lot of times those will show ST depression or T-wave inversion on an ECG. And then a STEMI, obviously, we know that that's an ST elevated. So you have ST segment elevation. This next slide here does show that ST depression there under B. It shows that ST depression that you could see with a non-STEMI, and then it goes on to show the progression and the ST elevation that you would see with a STEMI. lot of this is kind of review for you guys, but clinical manifestations, you got to think perfusion with the heart. And if we had decreased perfusion, what are we going to be feeling? So clinical manifestations are pretty classic with chest pain, shoulder and arm pain, shortness of breath, nausea, vomiting, sweating, fatigue. You could have some JVD or hypotension or bradycardia. It could be depending on where the occlusion is at, which coronary artery that the occlusion is, can bring up different manifestations for you. Keep in mind that women are likely to present with symptoms that are just a little different. Things like neck, shoulder blade, and jaw pain, sometimes abdominal pain, and then also some unclassic things that can be displayed are by our elderly. They may not exhibit just the classic angina symptoms. They may have dyspnea and syncope and just fatigue, confusion, and then also diabetics as well. They sometimes will not present with classic chest pain manifestations. So they could also just kind of present with just random, just short of breath and fatigue. So kind of keep that in mind, that women, elderly, and patients with diabetes a lot of times can present with non-classic type of symptoms if they're having a myocardial infarction. Okay, so there are certain laboratory tests and diagnostic testing that we do to diagnose a myocardial infarction. ECG, getting a 12 lead is a gold standard for diagnosis. So we can look at our actual ST elevation. So this next slide here shows our, can show where you, depending on where on the 12 lead you have the ST elevation, will let the provider know where in the heart the infarction is happening. So is it inferior or posterior or anterior or septal? It just depends. They know which arteries supply the blood flow to which areas of the heart. And that 12 lead breaks down into different portions of the heart. So just by looking at that 12 lead, they're able to get a picture in their brain of where the blockage is. Some of our lab tests that we do, we can call it a cardiac profile. These typically include troponin, creatinine kinase, and which is a CK, and then also a CKMB. So creatinine kinase MB is a marker that's very specific to cardiac tissue. Just plain old creatinine kinase is actual skeletal tissue. It's not cardiac specific. It's just somewhere skeletal muscle in the body. You could be having a problem. So sometimes they'll see the creatinine kinase just generalize increase, and that will tell them, oh, maybe I should get a CKMB and a troponin to see if this is more cardiac related. And then the cardiac troponin, this is our proteins that are expressed, and this is exclusively in the heart and are very specific markers for cardiac muscle damage. So the troponin and the CKMB are very specific to cardiac tissue. Okay. As far as treatment, our goal is to maximize oxygenation, control pain, and then dilate our coronary arteries. We also want to do things to prevent clots and to decrease the workload of the heart. So this goes on to talk about, if you think about MONA, we have our oxygen, nitroglycerin, aspirin, and then pain medication, which a lot of times is our morphine that you think about. So there's some other things that they could use too. We know that when we start looking at this, oxygen is pretty self-explanatory. The nitroglycerin is a big deal because that does actually dilate open our coronary arteries. And if we dilate them open, we get more blood flow, which means more oxygen to the actual infarction within the heart. So that's very, very important. Oxygen itself, they will typically put people on oxygen, but it does go on to say, if they're less than 90%, their O2 saturation, then they kind of maybe look at that and will put the patient on oxygen. Aspirin is a antiplatelet, so this is used to help prevent platelets from getting bigger. And then also, if you already have a clot, to prevent it from getting larger, and then also to prevent new clots from forming. So that's why we give an antiplatelet or aspirin. Another medication that you might want to think about is clopidogrel or Plavix. And these are also medications that they use to inhibit platelet activation as well. So you can look on 32.4 for more medications that are used for treatment of MI. Pretty much this is what we just got done talking about. Along with what I've already said, it goes on to talk about beta blockers. And we know from previous semesters that beta blockers slow down the heart rate. Therefore, they make it so our heart doesn't have to work as hard. And then if you do that, then you decrease the demand for oxygen. So that's why we treat patients that are having an MI with beta blocker therapy, if not contraindicated. And then thrombolytics, obviously, that's our clot buster. Those are our drugs that end in place, reteplase, acteplase. These actually dissolve existing clots in the artery. We know that you have to really be careful and watch for bleeding when we use any thrombolytics. This would be the same thing as fibrinolytics or clot busters. Okay, so basically the big takeaway is we want to do some type of reperfusion therapy. So we will either look at doing a PCI, which is percutaneous coronary intervention. It's kind of an umbrella term for stent placement or angioplasty, which I will go into. Or if you're at a place where they don't have that capability to do that, if someone's coming in with a STEMI, then we're going to look at fibrinolytics. And you can see there it says that when we use revascularization that occurs in 6 hours, that we can actually decrease the mortality rate from 70% to down to 38%. So it is a big deal to get these patients revascularized. If they're coming in with a STEMI, then the time frame to get them to the cath lab is typically within 90 minutes from door to balloon. And what that means is if you have a cath lab facility where these patients are coming into and they're coming in with a STEMI, then the team is already activated when the call is brought in from the paramedics to the ER. They activate the team and alert them to start coming in already. So then when the patient gets there, they work them up very, very fast. And from the time they hit the door of the ER to the time they're on the cath lab table and the provider is inserting the catheter and going into the artery and ballooning open the occlusion, that is door to balloon time. That should be 90 minutes or less. So that's what that's about. They do like to go through the radial artery if at all possible. There's less complications going radially, but sometimes they need to go femorally to get that done. And then fibrinolytics, I already talked to you about That's your clot buster. If you're at a feeder hospital and they don't have cath lab capabilities, then they will do fibrinolytics and then send them somewhere. Okay, this next slide shows just a picture there of what an occlusion in an artery could look like under angiography. So this would be like if they took them into the cath lab and they're looking using contrast dye. That's what they do to see where the occlusion is. So it's important to make sure that, you know, this is an invasive procedure. So obviously the patients will be signing a consent, and to make sure that their NPO, if possible, if they're having a STEMI, that sometimes is not possible. And then to always assess for iodine or shellfish allergies, because that could mean that they're allergic to contrast media. And that's what they use in the cath lab. Okay, this next slide goes on to talk about, again, I kind of already alluded to PCI. We said that that is an umbrella term for some type of intervention. So they can do a few different things. They could go in there and do an atherectomy where they remove the plaque. They kind of like have this little roto-rooter device that goes into the artery, and as it's quickly and fastly roto-rootering the thrombus, it also has this suction event on there, and it's sucking the plaque out. So they can do that arthrectomy. They could do a stent placement, which is like mesh or wire device that goes in, and then it you deploy it and it opens up and it packs the plaque up against the sides of the vessel and keeps things open that way. And then the other one there is a percutaneous transluminal coronary angioplasty or a PTCA, and that's just the ballooning. They can inflate and deflate a balloon multiple times to again, pack the plaque up against the side of the vessel. A lot of times they'll do a PTCA, they'll do the ballooning, and then deploy the stent to keep it open. When they do these, any of these interventions, this is done if there's like one vessel, you know, and they're able to see what they're doing and they can get to it. If there's multi-vessel disease going on, then these patients, a lot of times they won't be doing this, and they'll just say that they need to go have a CABG. Maybe they'll get the worst culprit that's causing all the damage to the heart. They may stent that and get that open, but then the rest of them, if they're high enough stenosis, then they'll say this patient needs to have a CABG. There's a lot of risks involved with having these procedures. Obviously, we're messing around with the heart, so we can have a dysrhythmia. You could actually impale through the vessel, which is immediate emergent open heart surgery if that happens. You could also cause plaque to break loose and travel. So that could go to the lungs like a PE, or to the head like a stroke. So there's risk of infection. So you could also cause a myocardial infarction, even worse, worsening of it. So there's a lot of complications that come along with having some sort of PCI done. Okay, our next slide here is just talking about those complications that I just talked to you about. You guys can read through these. They pretty much make sense, you know, making sure that you know, that there are these complications that can happen. The patient, if they go femorally, they have to lie flat for 2 to 6 hours to make sure that insertion site heals over. Otherwise, you could have bleeding, so they have to lie flat. So that's a problem, which is another reason they like to go radially. Also, you need to watch the actual insertion site for bleeding or hematoma formation. A lot of times we'll definitely be monitoring our patients on cardiac monitoring and doing frequent vital signs. we need to watch for recurrent chest pain. So these patients just went to the cath lab for a STEMI, and they did whatever intervention to open up the vessel. They should not be having chest pain. So if a patient complains of chest pain after stent placement, that's extremely important that you need to report this right away to the provider. You don't just say, oh, gosh, they're having chest pain again. They shouldn't be. They just had a procedure done for it. So we need to report this to the provider and make sure that they're aware. Um, Goes on to talk about watching for signs of stroke. We already kind of mentioned that. Monitoring our peripheral pulses, color, CMS in the periphery. So if they go in the right groin, then I want to make sure my right foot has good pulses and good blood flow to my right foot. Also watching our urine output. So we know that contrast dye is hard on our kidneys, it's nephrotoxic. So these patients will be getting a lot of IV fluid to kind of flush out our kidneys. This comes into play, especially with our diabetic patients. If you can remember back from Farm 2, a lot of these type 2 diabetic patients, the main treatment is metformin. And with metformin, we know that they need to be off their medication for 24 to 48 hours prior to having contrast dye. And then they also need to be off the medication 48 hours after the procedure because it increases the risk of kidney injury. So obviously, if somebody's coming in with a STEMI, we can't keep them off their medications for prior to the STEMI. So these patients will go and have this contrast dye as they have their stent placement. They're at a higher risk for kidney problems afterwards. So definitely it would be important to make sure that they didn't take any more metformin for 48 hours after that procedure. But that's why we're watching our kidneys so closely. And then obviously just watching our renal function, H&H, our coags, things like that. Okay. Complications of a myocardial infarction would be any type of heart failure happening or arrhythmias. So anytime we have a disruption in the heart and that muscle can die and have decreased contractility and function, then the result can be heart failure. The patients can have a difficulty with retaining fluid and having difficulty breathing and things like that. So we want to watch for any symptoms that you would see with that would be the same as heart failure to make sure our patients are not going into heart failure post myocardial infarction. This could even get to be so bad that they go into cardiogenic shock as well. So really watching our blood pressure and things like that to make sure everything's going okay. These arrhythmias, again, you're messing with the heart. So anytime you mess around with the heart, regardless of how you're doing it, patients can have dysrhythmias. So depending on the type of infarction they're having, some of them are more susceptible to having dysrhythmias, but just know that this is something that we definitely watch for post-STEMI. Okay, so then our nursing management, obviously, we're going to be assessing and analyzing and watching for signs and symptoms related to lack of oxygen for these patients. This makes sense to us. So interventions, vital signs, pulse oximetry, watching our ECG, and then watching for any decreased mentation, restlessness, confusion, stuff like that. And then definitely, like I said, since they went to the cath lab and, they had contrast dye, it's important to watch your urine output, and then also just the fact that the heart itself, the cardiac output, about 25% of it goes directly to the kidneys. So if you have a decrease in cardiac output, then you could have a decrease perfusion to your kidneys. So it's important to really watch your urine output. We'd be getting CMPs, CBCs, our coags, our PTT, PTINR, and then ABGs if needed as well. And then again, these guys, we'd be definitely watching our cardiac biomarkers, so our CKMB and troponins. A lot of times with the CKMB and the troponin, they will get serial CKB and troponin levels. So that means that they'll get multiple ones. So like they'll get that level, they'll get those blood tests Q6 hours times 3. And what they want to do is to see the numbers start to come and trend down. A lot of times these numbers can stay elevated for, like 36 hours, 24, 36 hours. So, and an actual troponin can stay elevated for as long as 10 days. So we definitely want to trend them and make sure our levels are on the downward swing so we know that we're not still infarcting. Okay. Sometimes they're not able to manage a STEMI by having a PCI done. And for whatever reason, if there's multiple vessels, or maybe it's a really hard to get to lesion, or it could be a critical lesion in the left main vessel. If that's going on, then these patients will be going for a CABG. This slide here, make sure you guys watch the little video there. It's about a CABG, but this just kind of shows the different vessels in the heart and how they can use veins from the saphenous vein from the leg. They can harvest that and flip it around and use it as an artery in the heart there, going from the aorta down past the blockage and bypass the blockage that way. They can also use vessels from inside the chest. They can use the internal mammary vessel, and that's what you see there on kind of the right side of that picture. They'll take an internal mammary off the heart and they'll graft it up there to bypass where the lesion is at. So they can utilize a couple of different things there. Okay, and here we're going to start talking about post CABG assessments. So obviously it makes sense that we're going to do a lot of hemodynamic monitoring, and I'll go more into the hemodynamic monitoring as we get further in this PowerPoint. But we're going to be watching our blood pressure and our preload and afterload by watching our CVP and things like that. We'll talk about a Swan-Ganz catheter or a pulmonary artery catheter that they can place in patients to help monitor pressures within the heart. So the gist of the story is we're getting lots of numbers. So we monitor things very continuously, about every 15 minutes, and then hourly for sure after that. And we're watching their continuous cardiac monitoring, watching for any type of dysrhythmia, listening to our heart tones to make sure we don't have bleeding within the chest and hear those muffled heart tones, which could be indicative of cardiac tamponade. So listening to heart tones is very, very important. And then, making sure our patients are warming up. We always do a slow rewarm. We don't warm people fast. Always a slow rewarm. Listening to our breath sounds, checking our LOC. These patients will typically come back on a ventilator, and then we get them extubated within 6 hours. And then we do start dangling them post-extubation within 2 hours, and then get them up to the chair within 4 hours. They're walking the next day. They're usually pretty grumpy about it. Chest tube output, we'd definitely be looking at the color and volume, and then monitoring our labs and our incision. As far as the chest tube output, do know that these patients come back with what's called mediastinal chest tubes. Up until now, we've been pretty much talking about pleural chest tubes. If somebody has a pneumothorax, they could have a pleural chest tube also, but they will come back with mediastinal chest tubes. That's just going into the mediastinum, the middle of the chest, and that's just to drain blood. They were cutting around on the heart. There's going to be swelling and drainage that happens, and they need to drain that blood. So if it doesn't drain the way it's supposed to, again, it could accumulate in the chest and cause cardiac tamponade, and the patient will code and die. So they do monitor this chest tube output. Any sudden increase in output greater than like 1 to 200 mils an hour, and that's not associated with like turning them on their side and dumping blood, then that could mean hemorrhage. And you know, you get special training on this to see if anything like that's going on. I have seen multiple patients have to return to the OR because of bleeding, and it happens more than you think. So this is the type of nursing that I did. Most of my nursing career is CVICU, so I'm very well versed in this. So yeah, you always watch for bleeding and hemorrhaging. As far as labs, you're doing everything from CBC, so we can watch our H&Hs. We're doing very close glucose control on these people. Our CMP to watch our kidney and liver, and then our coags, PT, PTT, INR, watching that because of the bleeding. Okay, I think that's what I want to say on that. Post-CABG interventions, obviously oxygenation. A lot of times it says insert 2 large bore IVs. That's cute. They have lots of IV access. They have typically a Swan-Ganz catheter that has IV access. That's a central line. And then they also have a central line as well, which usually has 3 ports. So they do have typically central line access. You will do continuous ECG monitoring. They'll be on bed rest until we get them up and get them ambulating, like I said, pretty quickly. Watching our fluids, rewarming our patients slowly, definitely administering pain medications, and pulmonary hygiene is no joke with these patients. We are very strict on them using their IS every hour while awake. They have to be doing it. So we encourage that definitely. And then making sure that they're doing sternal precautions, you know, really splinting their chest when they're coughing and things like that. As far as wound care on these patients, it's up to the provider. A lot of times they'll keep that dressing on for 24 to 48 hours. And then after that, then you'll change it daily. It depends, like I said, it depends on the provider. Usually the max amount of time they keep a dressing on would be 72 hours. And like I said, you are changing it every 24 hours though. There are some, again, provider specifics, and the important thing is to make sure that we keep that wound nice and clean and prevent infection. Okay, some teaching that we're going to be doing, definitely signs and symptoms of infection, especially with a sternal incision. Keep in mind that these patients, they saw through their sternum and then use rib spreaders to open and lift their chest apart. So their sternum, when they're done with that and their sternum goes back together, they wire it together and then close up the skin. Their sternum is very unstable and will be for quite a long time. So sternal precautions are very, very important. There's no heavy lifting, definitely for the first 4 to 8 weeks. And we teach these patients also to not bend at the waist and lift things up. They have to be able to log roll if they're laying in bed, and be able to sit up on the side of the bed without using their arms to push up off of the bed. They have to be able to go from a sitting position to a standing position by rocking, and then on the count of three, stand without using their hands to push off on the bed. Because anytime they do that with their hands, when they're pushing, that's causing pressure on their sternum. So that's the sternal precautions. Cardiac rehab starts pretty much right after discharge from the hospital. They don't wait around on that. Typically, within a week, they're going to cardiac rehab. So they do lots of counseling on exercise and physical activity and diet, education, weight management, things like that. They definitely look at modifiable risk factors and how to better that for the client. Um, what may we expect post-CABG that we need to educate about? All of these pretty much make sense. Lack of appetite just because they had a major event there. Insomnia will be difficult to get sleep, fatigue, chest discomfort. Usually for 2 to 5 weeks post-surgery, it's important to teach them about this. So coming back full circle here, we said that if somebody was having a STEMI or an MI, they may go to the cath lab, have a PCI, some type of PCI done. If that doesn't work, then they may have to go have a CABG. So now coming back full circle with the STEMI, teaching that we need to make sure and do post-MI is obviously teaching about signs and symptoms of a myocardial infarction, teaching about their medications, and what medications they be taking, and then also the American Heart Association Life's Essential 8, no smoking, trying to maintain a normal body weight, exercising, eating a healthy diet. So we want to really stress increasing fiber, increasing omega-3 fatty acids, avoiding trans fatty acids. Those are bad for you. Watching your cholesterol and your sodium. They talk about increasing foods that are rich in omega-3 fatty acids, like salmon is a great one. Those omega-3s help lower cholesterol levels and help decrease inflammation. Obviously, we would know if we were like by evaluating our care, we would know that our outcomes were good if the patient was able to resume normal activity, be pain-free and anxiety-free. We're going to start going into cardiomyopathy. There's a video here that you can watch that kind of talks about cardiomyopathy. So you can listen to that on your own. I think you may have to download the PowerPoint to listen to it. Typically, there's 3 different types of cardiomyopathy. You have dilated cardiomyopathy, which is the most common type of cardiomyopathy. This hypertrophic cardiomyopathy or obstructive cardiomyopathy is this is the kind that you hear about when athletes just kind of drop. Everything gets very, very stiff. So that's with the obstructive cardiomyopathy. You have this just excessive hypertrophy or this enlargement that happens. So the ventricle thickens, enlarges, and then just becomes very stiff, like I said, and obstructs the blood flow. And then restrictive cardiomyopathy is a little bit different. Still, the ventricles become very stiff, and but usually this is caused from something else, some other disease processes like I can't even say it, amyloidosis, sarcoidosis, things like that could cause this restrictive cardiomyopathy. So with cardiomyopathy, I try to just kind of, in my brain, if I think of like heart failure symptoms, they kind of go hand in hand. the ventricle or the heart is enlarged and therefore is not pumping efficiently. So when we think of not having efficient pumping ability, then these patients throughout their body, it makes sense that they could have chest pain, dizziness, palpitations, fatigue, shortness of breath. They could get fluid overload very easily, which is why I say also think of like heart failure symptoms. They can have a lot of swelling, difficulty lying flat in bed, that PND. They can get edema, pulmonary congestion. You might see or hear abnormal heart sounds, which could be indicative of increased fluid. And they could have JVD, enlarged livers, liver, I guess there's one. So anyway, just think of fluid overload. Some risk factors for these patients, diabetes, hypertension, sedentary lifestyle, pretty much anything that's the same with STEMI as well. Medications to treat patients with cardiomyopathy are some little bit different. This goes on to talk about your SGLT2Is. So these inhibitors, this is different than what we haven't really talked about this in pharm. I'll go over it into it more a little bit in class, but this would be your Jardians. They can also use these combination drugs, this angiotensin receptor and neprilysin inhibitors, or ARNIs. These are combination type medications. And then your ones that you do recognize would be your beta blockers. When it talks about mineralocorticoid receptor antagonist, that's just a fancy name for spironolactone. If you remember, spironolactone blocks aldosterone. And if we just got done with our endocrine chapter. Remember, we said mineral corticoids that is our aldosterone. So with aldosterone, we said aldosterone is a potent sodium conserver, and if you're hanging on to sodium, you're hanging on to fluid. So obviously, if we have an aldosterone blocker or a mineralocorticoid receptor antagonist, a blocker, then we're not going to hang on to extra fluid. So this, like I said, would be like your spironolactone. They will use other diuretics too, but you can understand why that would work really well. And then like digoxin, which is our positive inotrope medication. Always remember digoxin is never first-line treatment for anything, but if somebody is having symptoms and they're on other medications and they're still very symptomatic, they could add digoxin to try to help alleviate some of those symptoms like fatigue and dyspnea, exercise intolerance. You can see more in your book on on chart 32.5. I don't know what page that's on. It'll also talk about ACE inhibitors and ARBs and stuff like that too. There is one medication though that just before I start going on to this next slide that I want to talk about that they do not typically use, and that would be nitrates. So with cardiomyopathy, they will not give these patients nitrates like nitroglycerin, just because it's too drastic on these type of patients on their hearts. It'll drop their blood pressure too much, and it'll really make things really, really bad for them. So no nitrates with cardiomyopathy. So as far as other treatments, they may have a pacemaker inserted or an ICD because they're very high risk for dysrhythmias. There's a few surgical procedures that they kind of talk about that they could have. Your speaker notes talk more about it if you want to read about them. But kind of what I would focus on is as you keep going down here after those surgical management that they can do the different procedures, it talks about a left ventricular assist device or an LVAD, and then it goes on to heart transplant. So basically, as things get worse and worse and worse, and they're not able to help these patients with medications. They may have to do surgical management, and then if it's still not working for them, they could place a LVAD in a patient. Um, they can do permanent LVADs. Sometimes they can last up to 10 years. They have to carry like a battery pack on their waist and things like that. But they could have that done for them. And then obviously heart transplant are very, it's very hard to get a heart transplant. This would be only if the alternative would be death, you know, if they're going to have this. So maybe they would even get an LVAD because they were unable to receive a heart transplant or even make it to the transplant list. But these are considered only when other medical and surgical means have been exhausted. And then, like I said, the patient is at risk for death. That's when they would go to these other options. Um, Obviously, as I was saying, we're talking about our heart. So I said, if you think about heart failure, then you can see that's one of the major complications of cardiomyopathy is heart failure. And then another, you know, just because the heart itself is not able to, you know, meet the needs, it's weakened because everything's, you know, stretched out and failing. So heart failure makes sense that they would have a decreased cardiac output and problems with fillings. So like filling pressures. So dysrhythmia, this is very common complication of cardiomyopathy. A lot of times you'll see things like atrial fibrillation. They can also have very lethal rhythms like VTAC or VFib. Um, and these are the patients that obviously then would need ICDs or internal cardiac defibrillators. My own cousin had cancer and was receiving chemotherapy, and it destroyed her heart muscle, and she actually coded. Um, they got her back and were able to find out that she developed cardiomyopathy from her chemotherapy. So they fixed her up, sent her home, and she coded again. Luckily, she had what's called a life vest on, so it shocked her. She actually had a bad dysrhythmia because her ejection fraction, her heart function was so poor. So it shocked her and brought her back to life. When she went back to the hospital that time, they did put an ICD in her. And she has that defibrillator. And since going home from that, it did go off a couple more times. So she's doing good and healing well, but it's just kind of a little story about cardiomyopathy and how, you know, it happened to my own cousin. So and then anytime you have dysrhythmias or pooling of blood, then you can have a complication of thrombus. So because of this risk of thrombus, to reduce that risk, patients with cardiomyopathy are typically put on medications, platelet medications like aspirin or clopidogrel, or given anticoagulants like warfarin. They could even be given factor 10A inhibitors like rivaroxaban. So some type of anticoagulant because of the thrombus that could happen. Assessments, again, these all are pretty self-explanatory. The only thing I'm going to really, you know, just think decreased cardiac output, decreased perfusion, and that's why we're doing it. The only thing I'm going to kind of focus on a little bit here is with our lab tests. That's maybe a little different. They will be checking what's called a BNP, which is a brain natriuretic peptide. So B Nancy P is like what I try to say. That is an increase. Your body, your heart actually releases this protein or this peptide when the ventricle becomes overstretched. And if somebody's in heart failure, then you have overstretched ventricles. So a B Nancy P is a lab test that they will draw, and if that's elevated, then that could tell them that they're having fluid overload and heart failure symptoms or complications. Okay. Some interventions that they will be doing is obviously we already talked about our medications, different medications that they will be on. You know, we said our beta blockers, diuretics. They could put them also on antiarrhythmics because of the dysrhythmias. We said ACE inhibitors, ARBs, digoxin, oxygen definitely, especially. You know, we'd be watching their oxygenation. If they need to have more oxygen, then we would have to be supplying that. And then maintaining patient positioning. These patients, pretty much we would put them in semi to high Fowlers to help reduce preload and ease their breathing and their dyspnea that a lot of times that they experience because of fluid overload. As far as teaching signs and symptoms of heart failure, we would definitely be teaching them that because that is one of the main complications. We really would be talking to them about watching their sodium intake, making sure to weigh themselves every day, and reporting a weight gain of 2 pounds or more in 24 hours. When I did disease management for heart failure patients, I would teach them to get up in the morning, go urinate, take off their clothes, step on the scale naked, and to log their weight. And that's a very important thing to teach. That way, like I said, 2 pounds or more in one day, we would teach them to call their provider and let them know. So if you catch that weight gain before they start having symptoms, then we can get that fluid off before it starts to cause a problem. Obviously, would be dietary restrictions of fluid and, like I said, sodium. A lot of times they maintain them on even less than a 2-gram sodium diet. So sometimes it's even 1,500. So just one shake of a salt shaker can put people over that limit. It's amazing how much sodium is in salt. And then we still want to encourage them to exercise as they're able to. Nothing vigorous, but a lot of times they'll want them to go to cardiac rehab to help them with this. That way they can be monitored. So again, evaluating our care outcomes. As long as they have, we know we're doing good if there's no worsening symptoms, no unnecessary hospitalization, and then no unwanted complications. So this next slide is just like a little review for you on heart failure. You guys can look over the differences between the right and left-sided heart failure, what the clinical manifestations are, and then that comparison of heart failure, the stages there, you know, New York Heart 1, 2, 3, and 4. You can just kind of see, you don't need to memorize this or anything, but it's just so you can see how things get worse as the disease progresses. I did tell you that these patients sometimes will have an LVAD or something to help with that for end stage. So the picture of the guy on the left there is an animated picture of somebody that has an LVAD, and then he has there on his waist is his battery pack. This could be for patients that have end stage cardiomyopathy. It's surgically implanted, and like I said, this is only considered when all other means have been exhausted and the patient's at risk for death. That slide or the picture on the right is a picture of an intra-aortic balloon pump. This is temporary. This is a device that's only used for like 3 days or so, it just depends, in the hospital setting, just to help the heart rest. So basically they go in through the femoral, through the groin there, through the femoral artery. They thread a balloon device up the aorta, and it sits in the aorta, and it inflates and deflates with every beat of the heart. When it inflates, you don't have to memorize this, but just understand this. It helps you understand when it inflates, that does the inflation during diastole. Remember, when your heart's at diastole, your heart is at rest. You die during diastole, so your heart's resting, it's not pumping. During diastole is when you have most of the coronary blood flow to your heart. So if that balloon is inflating during diastole, when your heart's at rest, it's pushing the blood flow into the coronary arteries of your heart and helping your heart that way. Then when it deflates during systole, when your heart's pumping out the blood, by deflating during that time, it causes like this suction event, and it helps pull the blood out of the heart and push it through the rest of the body. So it makes it basically so the heart doesn't have to work as hard and it can rest. So this is like a little bridging device. And like I said, maybe 3 days they do it. They don't typically like to go longer than that. It's ran on a CVICU unit by a nurse that's specially trained to run an intra-aortic balloon pump. And then one other quick thing, they also have temporary LVADs that they can put in patients as well. That would be called an Impella. So those patients, or those you nurses that are at any CVICUs, you may see an Impella. That's a temporary LVAD on a very, very sick patient that's probably in cardiogenic shock. Okay, so progression of the disease, it says here, if we're having to give more invasive treatment to support the cardiac function, if they're having to have a implantation of an ICD or a pacemaker, then things are kind of progressing or maybe getting worse. If they have to go on continuous IV inotropy therapy, that would be like a continuous milrinone drip or dobutamine drip, that's your inotropes, then that could show that the progression of the disease is getting worse. I already talked to you a little bit about an intra-aortic balloon pump or a VAD that they may have to use. And then in the end there, it talks about palliative care for patients that are end stage with their heart failure or cardiomyopathy. Hemodynamic monitoring. So we're going to go into hemodynamics now. We got a couple of slides left here. So the big thing about this can be very intimidating, thinking about hemodynamics. Just think hemodynamics tell us basically how our heart's working. So we use this to assess cardiac and pulmonary status. Your heart and lungs are very, very related, and we can use it for early identification of things, and it can help support or guide our treatment of our patient. And then it says, assessing for shock, and that's very true. Some of the main hemodynamics that I want you to be aware of are here on this slide. It says cardiac output. You guys have already had like a little of, you've had some of this. I know I talked about this in Pharm for a fact. So cardiac output, volume of blood that's pumped by the heart each minute. Your stroke volume is the volume of blood pumped by the left ventricle with each heartbeat. Preload, I always said, think of volume, and preload is your end diastolic pressure or volume that stretches the right ventricle. This is reflection of the patient's fluid status. A measurement of preload, as we keep talking, will be your CVP or your central venous pressure. So preload equals volume, and then you can put in parentheses CVP. And then your afterload is, you should say, resistance, or what your heart has to pump against. So it's the force of resistance the ventricles have to overcome to eject blood into, out the aorta. So basically, if you think about your blood pressure, people that have a high blood pressure, then you think that their vessels or their arteries and veins are constricted tight, and that would be a high afterload. So a measurement of afterload is your SVR, your systemic venous resistance. So you can say afterload equals resistance, and then in parentheses write SVR, systemic vascular resistance or venous resistance. And then your contractility is the ability of your heart muscle to contract. So how strong your heart is pumping. Okay, this slide just talks a little bit about oxygen delivery, oxygen utilization, and oxygen consumption. So in your book, it does a really good job explaining this. Oxygen delivery is DO2. It's how much oxygen is delivered to your tissues. Oxygen utilization and oxygen consumption, they like to use VO2 and to say that this is oxygen consumption. And the way I think of this is the V, if you turn it on the side, it looks like a mouth, so it's consuming something. So this would be the relationship between the oxygen delivery and to your body and how much oxygen is extracted by your tissues throughout your body. So we can talk more about that. One measurement that's on your content outline is SVO2, which is a measurement that they can do to see oxygen consumption. So SVO2 is systemically, and I have an example in your speaker notes there. If you have somebody that has a central line in place, they can do it off of a PA or a pulmonary artery or a Swan-Ganz catheter too, but I'm going to talk about a central line. Those typically go in your right IJ, your internal jugular. Just think to yourself that that's right before it goes into your heart. A central line does not go into your heart. It sits in that big vessel, that big vein before it enters your heart. So with a triple lumen, they can take, that has a proximal, medial, and distal port. They can take the distal port and put special pressure tubing on that. It looks like IV tubing, but it's not. It's pressure tubing. And they can hook that up to there and they can plug it into your monitor and transduce what's called a CBP. So the other thing they can do is they can take an ABG and they can pull blood off of that distal port right there. And that's the respiratory therapist would do that. And they would look at that blood, run it just like they would run like an ABG, but this would be called a VBG, and they actually call it a mixed venous gas. So what they do is it says that oxygen consumption can be measured by obtaining a mixed venous gas, which they can get right off that distal port of your central line. Or they can get it from the pulmonary artery. This mixed venous gas is blood that is before the blood is oxygenated in the lungs. It's after it goes through your body and then before it goes back to the right side of the heart and before it's then pushed, into your lungs. It's considered a true mix of oxygen returning to the heart and an indicator of total body venous oxygen saturation and tissue oxygen utilization. So long story short, I can talk about it more in class. Your SVO2 is the most accurate representation of systemic oxygenation. That is the blood that is ejected through the left side of your heart, throughout your system, your tissues, throughout all of your body is extracting oxygen from that blood. And then as it returns to the right side of your heart, we're pulling a sample of that blood. Depending on what the levels are of that, a normal oxygen level on that would be 60 to 70%, or I'm sorry, 60 to 75%. If it's less than that, then it means that the body's basically has an insufficient supply of oxygen to meet the demands of the tissue. So that would be indicative that there's probably a decrease in cardiac output. The heart's not able to pump efficiently enough. But like I said, we can talk more about it in class. This is monitoring. So here's your hemodynamic monitoring. This shows this would be either an arterial catheter or a central venous catheter if we were monitoring a CVP, a central venous pressure, or your pulmonary artery catheter. This shows a phlebostatic axis here, this picture on the left. This point right here, right under the armpit nipple level, is where everything needs to be zeroed at. On that next picture there on the right, it shows an IV catheter going into the artery, and then it's connected to pressure tubing. It goes up into a pressure bag, and then there's a cable on that special pressure tubing that we plug into another cable, and we hook it onto our monitor to get a continuous blood pressure reading. Right in the middle there between that pressure bag and the wrist, there's a little device there. And if you look close enough, it says a transducer. That transducer is what needs to be leveled to the phlebostatic axis there on the left. A lot of times there's a lot more tubing than what this picture shows, and they can kind of coil it up and put it on a rolled up towel, like hand towel, and tape it on there. And then they take that rolled up hand towel where that transducer is, and they set it right level there at the phlebostatic axis. You have to have it leveled. Any type of hemodynamic monitoring, they have a transducer, and it has to be leveled to get accurate readings. So that's what this slide is all about. This next slide shows a picture of an arterial line. It'll make more sense if you guys click into those links there. It shows an arterial line video, and then it also has another link for arterial line setup. I highly suggest you watch those and get an understanding of that. Obviously, because you're going to have hemodynamic monitoring on your exams, and you need to know this. So this is a picture of an arterial line. As you can see, they use like a stabilizer after they insert it into the artery. They use a stabilizer to hold it in place, and it's taped down very well. Obviously, if this comes disconnected, the patient can bleed to death because it's in an artery. So that's what an arterial line is. Like I said, it's a continuous blood pressure monitoring. And then you might notice if some of you are in the ICU that they go by a map. A map is the difference between your systolic and diastolic. It kind of gives a mean pressure. Typically they'll say, oh, if you have a map of 65 or greater, then at least a map of 65 is considered the lowest necessary for perfusion of your organs, like your kidneys. So they like the map to be at least 65 or better. Okay, this next slide here shows a test that's done prior to insertion of an arterial line. This is called an Allen's test. With this, it basically says that whoever is inserting the arterial line, typically it's a respiratory therapist, they ask the patient to elevate the hand, make a fist for 30 seconds. While the hand is elevated, the respiratory therapist or whoever is inserting the arterial line, nurses can do it too if you're trained, they occlude the ulnar and radial arteries at the same time with pressure, while the hand is still elevated. And they would then open the hand, and it should appear white. While it's still like that, they will then let go of the ulnar artery. They'll release the pressure over the ulnar artery while they still hold pressure over the radial artery. And a good thing would be normal color returns in 7 to 10 seconds. For this patient, this would be a positive Allen's test. A negative test would be if the color does not return in 7 to 10 seconds, and that would indicate that there's insufficient blood supply through the ulnar artery. Now, why we're doing this is because I just said we just talked about radial arterial lines. So they're putting a line in the radial artery, they want to make sure there's still enough blood flow going through the ulnar artery, so we don't have problems with circulation to the hand. So it's important to understand what an Allen's test is and how a positive Allen's test would be obtained and that it would be good. Okay, the nurse's responsibility with an arterial line is setting up the monitoring system, zeroing it and calibrating it, making sure it's at the phlebostatic axis, making sure everything is the way it's supposed to be. And then they would have to make sure there's appropriate waveforms and watching for complications. That bottom line there that shows the red going up and down, that's a picture of an arterial line. That's a continuous blood pressure. So if you were a nurse taking care of these lines, you would be able to recognize a nice waveform that's an appropriate waveform. It's important for the arterial site to be kept in view to make sure we can watch for a risk of catheter dislodgement or if it comes apart, and that would be hemorrhage. The insertion site, an area distal to the site needs to be monitored for good perfusion. So we'd be doing CMS checks of our hand and making sure we had good capillary refill. Another thing they can do is put a pulse ox on the hand that has the arterial line on it and make sure we have good pulse oximetry, good oxygen saturation. It can tell you your perfusion. Another thing to prevent complications, to make sure we have alarm limits set, a high alarm and a low alarm, and then make sure we don't have the alarms turned off, which watch and see at your clinicals how many of your nurses turn off their arterial line alarms, which is very dangerous. That should not happen. Potential arterial line complications then, like I just said, infection because it's invasive. If you can have a occlusion of the artery, that would be bad if there was a clot that formed. Hemorrhage because of disconnection or the line coming out. That tubing, that pressure tubing is, we use normal saline to, what do I want to say, I'm trying to think of the word, but basically purge the line so it's all the way full of normal saline before we insert it. We want to make sure there's no air. It's going into an artery, so an air embolism would be a complication. And then obviously if the person doesn't know what the heck they're doing and they're using an arterial line, that could be a problem. If they have it up too high or have it down too low and it's not at that phlebostatic axis, you get inaccurate readings. And then usually we're using that continuous arterial line so we can titrate things like pressors and potent medication. So, and then obviously damage to an artery. Big time safety alert to make sure arterial lines are marked that no IV medications can be given through an arterial line. If that happens inadvertently, which I've never seen it in my life, anybody do that, but I'm sure it has happened. If it does, you could have tissue necrosis, gangrene, and loss of your limb. So no IV medications should be going through that line at all, and that needs to be marked that way. When discontinuing an arterial line, it isn't an artery. There is no sutures on these. I don't know why it says sutures. You basically remove the dressing and remove the securement device. I've never seen sutures on an arterial line. I don't want to say never, but they're not sutured. Anyway, after you remove it, you will be holding pressure for quite a period of time. It says here 3 to 5 minutes. Sometimes it's longer, and definitely if they're on any anticoagulants, you might be there for 10 to 20 minutes holding pressure. After that, you would wrap it with Coban to keep a pressure dressing on there and frequently monitor your site to make sure they're not bleeding. Because if they do start to bleed, like I said, they can bleed to death. Okay, central venous monitoring, great video in here. Go ahead and click on that and watch that video. But this is done, your CVP is done off of your central line. There's your 3 ports. They will hook pressure tubing up to the distal port and then transduce it to the monitor. And CVP, since it's going in the right side there, you know, right before it does not that central line does not enter your heart, but is right before the right side of the heart there, then that's a measurement of preload. How much volume is in the right side of your ventricle there. So CVP is a measurement of preload. It reflects the amount of blood returning to the heart. So just think your right atrium, right ventricle, and that has to do with your CVP and preload. If you have a high CVP, then that would tell me I have too much volume on board. Maybe they'd give diuretics, or they could give medications, venodilators that dilate open our veins, because that's a vein going into the right side of the heart, and that could lower my CVP. If my CVP was decreased, that reading could be indicative of like a low volume status, like maybe hypovolemia or something. And the treatment for that could be fluid boluses, also vasopressor therapy that would cause constriction of my veins, and that would raise my CVP. So think about what could cause a high CVP, what could cause a low CVP, and what you would do with those numbers to treat it. Okay, what can influence our CVP? I pretty much just talked about this. So volume status, or things to do with right heart failure, or increasing our intrathoracic pressure, things like pneumothorax, pulmonary hypertension, cardiac tamponade could definitely elevate my CVP. And then, like I said, a hypovolemic type status could, or low volume status could lower my CVP, and then I would do fluid boluses. Nursing implications for central venous monitoring. We would want to use central venous monitoring for routine fluid measurements, so we can see how well hydrated our patient is, what their volume status is. Also, we could use that CVP or your central line there to give more potent medication administrations, like your pressors and stuff like that. So we could also use our central line for volume resuscitation, frequent blood draws, TPN. We could use it for transvenous pacers. I mean, all of these make sense. 3% saline we would use through a central line, amiodarone, potassium. And then I said all of our vasopressors, pretty much you should have it on a central line because they're caustic to the tissue. We want to make sure our central line is very well secured, make sure alarm limits are set if we're monitoring a CVP, and then if we're also monitoring a CVP, to watch our waveforms. It's important to watch for infection or any bleeding. Just like an arterial line, complications would be infection, air embolism, any dysrhythmias or arrhythmias, especially if that line goes too deep and starts messing with the heart, because it shouldn't be there, and then bleeding. Our last thing to talk about here is our pulmonary artery pressure, or a pulmonary artery catheter, or a PA line, or a Swan-Ganz catheter. This is a device that you would use for typically a cardiac patient. Pretty much the only times I see these being used are for patients that have open heart surgery, like a CABG. They'll come back with a Swan-Ganz or a Swan or a PA catheter. The nurses like to just call them a Swan. So this will give us pulmonary artery pressures. They tell us the right sided heart function, and let us know how our lungs are doing. You can see in the picture there how it's inserted. It's inserted just like a central line into the right IJ, and then it's threaded down. I actually have one, and I'll bring it to class and show you guys. You can pass it around, but it threads down through the right IJ, down through the right atrium, into the right ventricle, and then you can see it looping back up, and it sits right before the pulmonary artery. In that third picture, you can see where it's just sitting at the pulmonary artery. Then if there's a little balloon on the end, if you inflate that balloon, it'll actually travel up and occlude the pulmonary artery. You can only do that for a few seconds, or you can infarct your pulmonary artery, which would be awful. And that by blowing up that balloon and occluding that pulmonary artery, that'll give us left-sided heart pressures. So basically, you have to watch the waveform, and it shows a waveform on there as it's going through different areas of the heart. Clearly, if we're putting this through the heart, we could cause somebody to go into VTAC. That definitely happens, and you can actually see it there when it's in the ventricle. And yeah, so these things are pretty dangerous. You have to really know what you're doing to take care of a patient that has a PA line on or in them. Like I said, these are usually your heart patients, so your CVICU nurses are very well versed in how to take care of a patient with a swan or a PA catheter. When they're putting in a swan or a PA catheter, a lot of times they like to have these patients in Trendelenburg position prior to insertion, just to make sure if there's any type of air bubble that goes or something like that, that it doesn't go up to the brain. So they like to have them in a Trendelenburg position. That's something that you should just kind of keep in the back of your brain there. Everything, like I said, is monitored very closely when they're inserting these. And the big takeaway for a PA catheter is it gives us pressures within different areas of the heart that gives us more numbers. And that way it drives our treatment of certain medications, especially inotropes and things like that, when we want to unload the heart and so on and so forth. So it just gives us more numbers. Cardiac nurses love numbers, and therefore we can titrate our medications to get our heart to have the most efficient cardiac output as possible. Complications, there's a lot. So obviously these are very complex and intense catheters. They even try not to use them as much anymore just because of the high risk of problems that can happen with these. So obviously you can have risk of infection and bleeding. If you're PA, if you insert that, if you blow up that balloon, you can have balloon rupture, you can have air embolism, you can rupture or infarct your pulmonary artery. So they're very dangerous, and you have to be very confident in how to use them. This last slide here, oh my God, I can't believe we're done. The last slide here is just a table that talks about different values that we just went over. So this is straight out of your book. It talks about what the normal values are. On your exams, you'll be given normal values, and then what it means if they're low, what could be going on, what could be going on if it's high, and then what your intervention could be. Again, I would just focus on central venous pressure, and then as you go down, cardiac output, I think you should be aware of, and then systemic vascular resistance, or SVR. The very bottom one says mixed venous oxygen saturation. That's your SVO2, and again, that tells you how well your body is utilizing oxygen. You do need to know what that is. That's on your content outline. Okay, guys, we made it. I know this is a lot of brand new information as far as hemodynamics, but we'll talk about it more. You'll have an entire clinical, or I'm sorry, skills lab day devoted to it. And then we'll talk about it in class as well. So bring any questions that you have to class. Thank you.